Hi, and welcome again to the AJNR podcast. I'm George Vilanilam, the Associate Podcast Editor. Today, I will be discussing an article titled Maximizing the Conspicuity of Cerebrospinal Fluid, or CSF, Venous Fistulas on Computed Tomography, CT Myelography. Assessment of Contrast Density and Timing Effects by first author Daphne Zhu. Let's start with the clinical problem here. Cerebrospinal fluid, or CSF venous fistulas, are now recognized as one of the most common causes of spontaneous intracranial hypotension. But as many of us who read these studies know, they can be incredibly subtle, and detection often hinges on identifying a small amount of contrast opacifying a paraspinal vein, and missing that finding can mean missing the diagnosis entirely. So over the past decade, multiple technical refinements in myelography have been proposed to improve the detection of these fistulas. So these include lateral decubitus positioning, respiratory phase optimization, and the use of newer imaging technologies such as photon counting detector CT and cone beam CT. But an important technical question remains sort of unresolved. When performing computed tomography myelography, CT myelography, what actually matters more for detecting cerebrospinal fluid venous fistulas? Is it the timing of image acquisition or the density of contrast in the adjacent cerebrospinal fluid space? And some centers favor dynamic protocols with rapid imaging after contrast injection to capture transient opacification of the draining vein, while others emphasize patient positioning and contrast pooling, aiming to maximize the contrast density near the suspected fistula site. So this study set out to directly evaluate the relative importance of these two factors. So how was this studied? The authors performed a retrospective review of patients with spontaneous intracranial hypotension who had confirmed CSF venous fistulas. So to ensure diagnostic certainty, only fistulas classified as definite using the Duke CSF venous fistula confidence score were included. The final cohort included 144 patients with 149 confirmed CSF venous fistulas, 222 CT myelograms, and 697 individual imaging acquisitions. And if you're following along with the images, Figure 1 shows the study flow diagram outlining how the authors narrowed down to this final cohort of patients and fistulas that met the strict diagnostic criteria. So just briefly about the myelography technique at this institution, the standard evaluation for spontaneous intracranial hypotension includes decubitus computed tomography myelography, and each study began with a single intrathecal injection of 10 ml of iodinated contrast, after which the patient remained in the lateral decubitus position, and to encourage contrast pooling in the thoracic spine where most CSF venous fistulas occur, the patient's hips and head were elevated using wedges and pillows. And images of the entire spine were then acquired in the right lateral decubitus, left lateral decubitus, and prone positions during maximal inspiration. So both conventional energy integrating detector CT scanners and photon counting detector CT scanners were used. And all acquisitions were reconstructed at very thin slice thickness to optimize visualization of small paraspinal veins. So for each acquisition, the investigators recorded the contrast density in the ipsilateral subarachnoid space, the time of image acquisition after contrast injection, patient positioning and scanner type, and then they assigned a Duke CSF venous fistula confidence score to quantify the conspicuity of the fistula. Let's talk about the key findings in this paper. If you look at Figure 2, you'll see a really helpful visualization of the data set. And each row here corresponds to a single patient and fistula site, and each dot represents a CT myelography acquisition. What stands out immediately from this graph is that higher contrast density in the ipsilateral subarachnoid space consistently correspond to higher diagnostic confidence. And statistically, both higher contrast density and shorter acquisition time were associated with improved visualization of CSF venous fistulas. However, when all variables were analyzed together, contrast density had a substantially larger impact than just timing. In fact, the effect of density was approximately 4 times greater than the effect of acquisition timing. So for every 100 Hounsfield unit increase in contrast density, the likelihood of detecting a fistula increased by about 14%. The optimal target contrast density described in the paper was approximately 836 Hounsfield units, very close to the 850 Hounsfield unit threshold suggested by other prior preliminary studies. So, sort of understanding the mechanism, here we see figure 3. It sort of further illustrates this point by grouping scans according to diagnostic confidence. The mean contrast density in the ipsilateral subarachnoid space was significantly higher in scans where the fistula was definitively identified, while acquisition timing differences were present but less pronounced. Moving to figure 4, this provides a physiological explanation for the observation. The authors demonstrate that as contrast density increases in the subarachnoid space, the density of the draining paraspinal vein also increases. So in other words, the more contrast that accumulates around the fistula, the more likely it is to opacify the draining vein, which is exactly the imaging finding we are trying to detect. So to sort of round out the practical implications of this study, this figure 5 examines the false negative rates across increasing contrast density thresholds. So what you see is a steady decline in false negatives as density increases. And at the optimal threshold of approximately 836 that we talked about earlier, the false negative rate falls to about 12%. So this finding reinforces the central message of the study that contrast density matters more than timing. So what does this paper tell us? For those of us performing or interpreting computed tomography myelography, this study provides clear technical guidance. While rapid dynamic imaging can help capture transient fistula opacification, these results suggest that maximizing the contrast density in the adjacent CSF space should be the primary technical goal. So in other words, contrast pooling may be more important than contrast timing. And this also explains why lateral decubitus positioning, which helps promote contrast accumulation along the lateral spinal subarachnoid space, has consistently been shown to help improve detection of CSF venous fistulas. So my final thoughts. Overall, I believe the study reinforces how small technical details in imaging protocols can have a major impact in or on diagnostic yield, particularly for CSF venous fistulas. Prioritizing high contrast density near the suspected level may improve visualization much more effectively than relying solely on rapid dynamic acquisitions. Before we wrap up this episode, I'd encourage you all to take a look at this graphical abstract on the AJNR website. It provides a very clean visual summary of the study and nicely illustrates the central message. Thank you, and until next time.